Well, I have the pleasure of introducing Hamid Ghanadan, who I would take up all of our time, I think, trying to truly go through all of his accolades. But I will summarize Hamid's career in saying that he is the CEO and founder of the Linus Group. And his career and work really is centered around helping healthcare leaders really think about making transformative decisions and thinking critically about how they approach problem solving. And so I'm really excited to talk to Hamid about digital therapeutics and sort of the potential impact of this new technology. So Hamid, if you'll join me on stage, that'd be great.
Thanks. Hi.
Before we get started, anything that you want to add in terms of the intro?
That was, I hope I live up to that. Thank you very much. This is, for those of you who just listened to the last talk about data and technology, I'll just preface by saying that you might be disappointed because I'm not going to talk a lot about technology. I'm going to talk about human beings. So I look forward to the conversation.
Yeah. Well, thank you again for spending time with us. I've been really looking forward to this conversation as well. And to Hamid's point, some of what we'll discuss has certainly been introduced, I think, in the last panel discussion around data. But as I think about, the fact that we could talk about this concept of technology and digital therapeutics for hours, we could go in a number of different directions. But let's first maybe establish a center of gravity in terms of thinking about, this notion of healthcare moving into the home and that shift, right? I think oftentimes, especially today, we talk about it in the context of the pandemic, and there's this lingering question of whether or not it's permanent, right? Are we going to continue to see this, here to stay? Digital therapeutics, I think, can play a huge role in this migration for sure, but there are certainly big psychological sort of potential burdens, potential hurdles to think through, especially with respect to certain populations, as the last panel discussed, right? When you think about their response to technology and all of that. Your firm, the Linus Group, has certainly done a couple of studies recently that I think sort of tackled some of these topics in terms of validating that shift to home, but also thinking about the challenges. Can you maybe start off by talking a little bit about that work and those findings?
Absolutely. So I'll just maybe introduce what we did and then what we found. We were looking after this idea of whether the pandemic is actually creating long-term changes in the behavior of the population. So we actually decided to focus on a group of population of health seekers that we believe have an ongoing relationship with healthcare. And so we decided to do a survey of 1,000 respondents in the U.S. between the ages of 60 and 79. And, this is not a group we didn't select for people who had chronic illness or anything like that. We just basically went after the general population. And we got some really interesting information about it. So that's one of the reasons why we chose this population of respondents. The other reason is because it's a really huge market. So by 2030, there will be 93 million Americans that are that are 60 years or older. And there was a study by McKinsey that showed that by 2025, so like just around the corner in healthcare timescale, $256 billion of Medicare services are going to be delivered at home. So big market, big dollars, and it's absolutely shifting. So we wanted to see what's up, and so we did the survey. Here's what we found: 2/3 of all of our respondents say that they want to stay at home as they get older, even if it means that they're tracked by a technology or that they're dependent on others. It is of utmost importance to them. So this trend toward definitely healthcare at home is real, it's big, and it's continuing to grow from that perspective. The other thing that we found to be quite interesting is that we tend to think of this audience or this market as essentially sick, not really caring or spending money on their healthcare, and being technology laggards. And our data actually busted all three of those myths. 68% of these people, of these respondents, actually had a positive view of their health, at least within the next 5 years. 81% of them said that they prioritize health in their lives, which we then dug into and realized that also translates to expenditure. And when we actually measured them along the technology adoption curve, so I'll talk about technology adoption curve really quickly. So essentially any population adopts technology and it shows like a bell curve with the super innovators being on one end or visionaries being on one end and laggards being on the other. Yep. This group actually over-indexed a little bit on early adopters and under-indexed a little bit as laggards. So this is a group that wants to stay at home. They're inviting technology into their home, and they're willing to basically make trade-offs for it because they are prioritizing their health.
It's such a departure from how we think about that population.
Absolutely. And I think that's part of the issue, is that when we're developing tech or healthcare solutions, we think of that like the generalized population of what we imagine those respondents to be, not the actual real people that are there and are an opportunity.
Yeah. I think that's a good segue into maybe the broader way we've been thinking about this conversation, right? Just from a couple of different vantage points, knowing who's in the room, both, on one end, you've got innovators, founders, entrepreneurs. On the other end, you've got leaders of integrated health systems, et cetera. But we all have this common goal of trying to prepare and propel, right, this healthcare system forward, especially in the wake of technological advancement, as well as the shift into the home. And if we're going to achieve this collective goal of improving outcomes, reducing inefficiency, reducing costs, et cetera, we certainly have to crack the code, right, when you think about motivating the right behaviors. And so my question to you is, how do you think about this idea of choice architecture, right? How do you think about improving trust between patients and providers so that you really are starting to see people indeed be open to some of this newer age technology?
Yeah. So I'll address that in three sort of facets. So choice architecture, we have to also understand the interplay between data and emotions. So I'll just dispel something here. The first misperception that we have is that if you give people information, they'll make the right decisions and they'll act on it the right way.
This would have been solved a long time ago if that were true.
Right? This can't be farther from the truth. People don't act on information. Every decision, everything that they do is rational to them at the time, at the moment. Seemed like a good idea, but that's not how the world actually, that's not how humans actually change behavior or take actions. So data are important. Data actually and evidence is really important. But just flooding people with data does not make them change their behavior. Right? So everybody knows that data, that logic and emotion are at interplay with each other. You take information, but it's emotion that actually drives your actions. There's another axis, though, that we have to take into consideration, is the audience that you're giving the data to, whether it's a patient in front of you, whether it's a doctor in your healthcare system, or somebody you want to adopt your tech. You have to understand whether they're first open. There's an openness scale. Are they curious? Or can you get them to be curious? Because otherwise, they're going to be skeptical. And so no amount of data is going to penetrate through their skepticism. And so we always ask ourselves, before we sort of give them the evidence, can we get them to be open? Can we actually get them to be curious and emotionally invested? Then we give the data in two stages. The first stage is just getting the recipient of that data just to formulate a hypothesis. Is this for me? Is this something that I should care about? That I should truly care about? You got me interested. Now give me enough evidence so that I can make up my mind as to what my hypothesis is around that. And only once they have that hypothesis, then you give them the data to validate their own hypothesis or to essentially just, overcome their skepticism, but also to personalize it to themselves. So that's how we think about the interplay between data and emotion. No amount of data lakes, no amount of AI, no amount of anything is actually going to overcome this 3 stages.
Yeah.
I shouldn't say never, but it hasn't up until now to do that. The second part that you brought up is choice architecture, which is this concept, this science that says the way in which you present someone with a choice, the way that the choice is presented actually has an effect on the outcome of the choice that they make. And this has been a topic around behavioral economics, that people don't do rational cost analysis and make the rational choice. And so when you're thinking about choice architecture, here's the second misperception, is that you have to change beliefs in order to change action. And that's not always the case. I have a young daughter. She hates to hike. She hates hiking. She's been on many, many different hikes for many, many different miles for her entire life. Why? Because we introduced the idea of a different kind of an experience to her. We asked her to experience hiking rather than to conceptualize hiking, which she thought she hated. So what we did was we essentially said that lollipops are consumed outdoors. And so every time we went outside, we gave her a lollipop ever since she was really little, and she was walking around, having her lollipop, enjoying the outdoors, and we were all enjoying a hike as a family. You can actually bring people into experiencing a new behavior instead of working really hard to change their cognitive beliefs. And so choice architecture can be really powerful in that. You can gamify something. You can incentivize. There was a conversation just a minute ago about incentivizing people to lose weight. Those are all ways that you can invite people into an experience without having to change their beliefs. And then you brought up trust. And I think it's really important in the concept of digital therapeutics to really think about the concept of trust. It used to be that in your patient-physician relationship, you trusted your physician, and then when they prescribed something to you and gave you the side effects, you trusted them. You didn't actually. I didn't know who the medication that I was taking was manufactured by. I never read the clinical trial studies. I didn't go into adverse effects to really understand what was going on. I trusted my doctor, and I did this. With digital therapeutics, it's a different ecosystem. There's more actors and players that are possibly at play. The technology in which it's delivered. Who or what is actually giving you that initial recommendation or that prescription? Right now, I can actually go online, fill out a form, and get a prescription that I want. No actual human being. Maybe there's a human being on the other end. I hope there is, but I don't have experience, so the trust is not built there. I maybe experience my tech through my iPhone. Do I trust iPhone enough with my, with the data? Who's looking at it? There's payers. There's so much of this ecosystem. And so in order for people to act, there needs to be one stake of trust in the ground. That's essentially one of the key areas. So whether that's your brand, if you're a digital therapeutics innovator, or the tech that actually delivers your therapeutic, or how you're developing your articulation, there needs to be that pillar of trust. It's also really important to understand how trust is broken, especially in the digital therapeutics world. So at Linus, we have a digital health lab, and we tested 8 different digital health offerings. And these were, some of them were consumer-based, some of them were mental health or behavioral health technologies. Some of them were wearables, and some of them were actually diagnostics. And they required us to send a sample or a continuous glucose monitor or something like that. And I can tell you that across all of them, there was one moment where trust was broken, and this was kind of unilateral among everybody who tested this. It was the moment that system failed to adjust to the daily lives of people. So as an example, we had somebody that was testing a weight loss app, right? And so they had basically filled out a questionnaire. They said, this is how much weight I want to lose. And then they asked, how fast do you want to go? And so they did this calorie restriction. It calculated everything. And this person was entering all of their data in on a daily basis. And they were getting personalized information back as far as, I mean, this person was entering their daily weight, their exercise routine, their calories, as well as logging food, like, kind of religiously. And that person met their weight loss goal. And the system didn't adjust, right? So instead of saying, congratulations, you've met your goal. Now let's get on to another program where you can, maintain your health and go that way. No, it was still calorie restriction. It was still giving them information and content about how you can continue to lose weight. And trust was broken at that moment. Another person was wearing a wearable where they were measuring their energy level and their recovery. And this person broke a toe, actually exercising, playing soccer. She broke a toe. And there was no way for her to basically pause the now irrelevant information that she was getting from her wearable in order for her to come. So trust was broken almost always. And this is the issue with a lot of AI systems and this, that they're linear, right? How many of you have ever searched for anything online to purchase? And after you've made your purchase, you see ads for it for another month. Dude, I already bought those sneakers. What else do you want from me, right? That's the linearity that this whole data ecosystem hasn't been able to break yet. And it actually breaks trust. We saw it in the digital health lab that we saw. It was one of the biggest things that we found, actually. Yeah. So a lot of topics around this choice architecture, but it's critical if we actually want people to change their action. Yeah, you couldn't be more right. We're just starting to, I think, scratch the surface when you think about some of the challenges that exist along the provider work stream. When we think about this concept of adopting digital therapeutics, you mentioned it. We live in a world where there's a million different drug therapies, treatments, et cetera. And you've got a lot of companies that are focused on, helping us kind of through this selection process. One example being Amerisource, kind of thinking about their tool, DTX Connect, which helps, physicians sort of figure out or use a catalog rather to order and then prescribe different items. And we touched on this a little bit, but maybe how do you think about helping doctors feel empowered to use these new tools, especially given things like potential fraud, as well as the concept of integrating these new tools into kind of mainstream medical education, right? Because it's all new. Yeah. Oh, absolutely. So I think about it through the lens of just technology adoption. And again, the technology adoption curve that talks about how people will adopt technologies at different scales. So when you actually study this, there's two things that drive technology adoption. One is a perceived cost. So if these doctors were to adopt a new technology, they're paying for it in more than just money. And to understand what is important to them and how much you're asking them, what is the cost that they're bearing in adopting that technology, will determine whether they will adopt it and when they will adopt it. The second one is risk, like you just mentioned. So people who are on the front half of the technology adoption curve, they tend to discount risk for the promise of the benefit. And the people the second half of the technology adoption tend to be driven by risk. So they really value risk mitigation more than promise, right? So we get that. Here's the thing about the cost. So for example, if your tech is trying to be adopted by physicians, and we know that a lot of physicians, one of the main parts of their job satisfaction is actually sitting face to face with a patient, and really that patient encounter is really important to them. It's of value to them. Then if you have a tech that actually takes them away from that or reduces that, then that's an emotional cost that they're bearing. So whenever we're helping a company get ready for commercialization, we're always looking for those psychological costs. What is it that we're asking these people to give up? And is that a value to them? And then could there be another value that gets balanced. And so that's really important for us to understand. And then the risk, absolutely. So the second half of the people, you have to demonstrate how you're mitigating risk and how you're lowering risk. And you cannot get people who are just naturally, innately risk averse to adopt a technology that they deem to be risky.
Yeah.
They're not going to adopt it, and if they adopt it, they're not going to use it effectively. And so your value proposition is sort of negated in that situation. The best thing to do is just to capture as much evidence early on from those early adopters, and then share it incessantly with the late adopters, so that they're actually gaining an experience as to the fact that this technology is mainstream. It's more safe to use, and the benefits are real.
Yeah, so it's not kind of forcing it on them, right? It's just a natural sort of evolution of sorts.
Yeah, you can squeeze the time for technology adoption or elongate it, but you can't break it.
Yeah. Maybe let's unpack or talk a little bit about the variance across use cases and sort of different types of illnesses, right? Digital therapeutics, I think the first sort of use cases were certainly for physical, illnesses such as diabetes, and it's now expanding into new areas such as mental health. So when you think about some of these more complex emotional issues like trauma, for example, how do you leverage digital tools in a way that does not, make people feel even less cared for, by this system, given that there is less human interaction, and that's just kind of where we are.
Yeah. Yeah. So we actually looked into this in several different surveys that we had done. So first, let's talk about the fact that we as a society, or at least the healthcare, what we've done is we've told we basically said we want patients to be empowered, right? We want them to have choice. Mm-hmm. And so, in the US, we call that consumerism. And so we're saying they're not patients, they're consumers, because that's what it emblemizes the sort of choice and control.
The autonomy is
right, exactly.
Yep.
So I don't know to what extent we're there or whether it's fair or not, but I can tell you that actually is a signal that people are getting. You're on your own. Is basically what we're saying.
Yes, confirmed.
So now, based on our studies, we're actually finding some really interesting things. And it goes back to that idea of the cost that people are... In some cases, people actually see that lack of interaction as a cost. Mm-hmm. And they're less likely to adopt it, and they're not feeling as cared for. Where we say that the front door to healthcare is closing. And so what happens with these consumers is they're looking for alternate doors. They're like, is there a side door? Is there a back door? How can I actually get into healthcare? And so they're looking to formulate better relationships with their pharmacists, for example, or they're consulting online. So those are examples of this side door, back door way of getting the care that they want. We heard actually that a large electronics retail center. That a large proportion of their inbound customer care calls were from people that were elderly and they just wanted connection. Like this is,
just to know someone was on the other end
exactly.
of the phone. Yeah.
And so this idea that actually tech is making us feel more lonely and less cared for is real. Now here's the interesting part around healthcare. And I mentioned it kind of depends on that cost. Now here's what blew our mind. Remember the 60 to 79-year-olds that we just talked about that we surveyed? They want to be in charge of their healthcare, thank you very much. Mm-hmm. Only 40% of them said that they trust their doctor more than they trust themselves about their healthcare. And that was, okay, so that was interesting. Mm-hmm. We also did another study where we actually surveyed Gen Zers, adult Gen Zers, so Gen Z expands a wider range, but the adult ones are between 18 and 25 now. They want an actual doctor to have a relationship with and go to the doctor. These are the digital natives that we're talking about, right? But the Gen Zers have actually been fiercely terrestrial in their experiences. They want to go to the mall. Now they're having a digital experience or a hybrid haptic experience when they're there, and the same thing actually applies to the way that they want healthcare.
Yeah.
So they don't see that. They see that they have a cost of this idea of isolation and loneliness much more than the 60 to 79-year-olds that we did. So you can't so you can't break these two things apart. It's all about that idea of which costs are being discounted and which costs are really important.
Well, and so much of it is about balance too, right? In terms of what's being thrown at the various populations, right? As well as the context, right?
Absolutely.
In which they've grown up.
Absolutely.
So
as digital therapeutics come into play, I think we need to take that into account. That some groups are looking for this blended haptic experience. There needs to be something terrestrial in that experience. If it's all 100% digital, at least some groups are not going to feel satisfied.
Yeah. So. Yeah, you can't solve it for everybody with one sort of blanket solution. So the $1 million question, right? We've talked about, the layers, the complexity, this idea of trust, distrust, especially dependent upon certain populations. Are we as a society really ready for digital therapeutics? What do you think?
So if digital therapeutics deliver real benefit, meaning that there's a win-win-win situation, if they actually deliver healthcare to the patient population, and if the healthcare system can be more efficient and the economics are right, then I actually think that we shouldn't wait for society to be ready for us. It's up to all of us to make sure that society is ready to accept. I mean, this is where communication, this is where understanding humanity and essentially lowering the burden and the barriers to adoption, that's within our control. Within, if you're a healthcare system or if you're a founder or an innovator, that's part of the job, is to kind of develop the market.
Yeah, it's sort of why we all, right, have gotten into this work, right? Why we show up every day.
I agree with you. Here's the interesting thing. So it feels like society is finally ready for the electric car. Would you agree that that's the case? I mean, you certainly see a lot of companies are introducing electric models, right? And what? Electric cars were invented when? Like 30 years ago, 40 years ago? Does anybody know? 190 years ago. It was 100. You're saying 100 years ago. Absolutely. So the very first electric car was actually in 1832. So 190 years ago it was invented. And then it became sort of popularized right at the turn of the century. Thomas Edison was thinking about, okay, there's going to be a battery problem with this whole thing. It took 190 years from the very first instance. And here we are now, Ford and Chevrolet are moving in that direction. Let's not wait 190 years to change healthcare. Let's certainly not wait for society. But it is really important to find out why, right? And what happened was, in that situation, they were thinking about it from a technology perspective, right? And then here comes Ford and says, okay, we're gonna actually innovate not on the technology, but we're gonna innovate on the operations. We're actually gonna mass produce this thing. So that's gonna significantly lower the cost of ownership. And then the second thing we're gonna do is we're gonna make it stupid easy to drive. Right? So a lot of these electric cars didn't have steering wheels. They had rudders. It's this thing that's sits in front of you and you just kind of rudder your car because that's how boats were ruddered and all that stuff. But, so essentially they made it easy to afford and easy to own and easy to drive. And so then it started to take off, and there goes the electric car. And now the electric car is mimicking all of the usability that the gas car had. So I would actually say, are we ready for society rather than is society ready for us?
Yeah. Maybe shifting gears a little bit, in my role, I look at a number of different business models, including some of these innovative care delivery platforms, which are really focused on kind of challenging that status quo, right? A lot of what we've been talking about, especially in the context of health equity. For example, I had a conversation with a founder a few weeks ago of a movement called When We Trial, and her focus, her mission is to increase the number of Black women that are included in, oncology trials, for example, just kind of noting that, the care, the number of scans, all of that is increased, and you just, get a better experience through trial participation. And one of the things we talked about is also as a society, we sort of have gone through this global trial. If you think about COVID vaccination and sort of, different segments of the population and their inclination to be vaccinated versus not, depending upon their history with the healthcare system. So my question is, how do you think socioeconomic factors sort of play into all of this, noting that it may not be your sort of focus area day to day, but just, how do you think about that?
Yeah. So social determinants of health is not my expertise. However, I can talk about it through a behavioral lens. First of all, representation is critical. I think not only does it make absolute scientific sense, like I cannot think of a counter argument as to why you wouldn't want to have representation for a group that you're trying to serve. I can also tell you that that when people are seen, they're much more likely to say yes to something. So people say yes to those that they deem to be like them. Now, like them is a broad definition, and it can absolutely happen. It can cut across cultural divides. It can cut across many different socioeconomic divides, but you have to generate that level of likeness in order to say yes to those people. And so when, for example, Black women see that they are represented in a particular trial, they're much more likely to trust that therapy that's offered to them, but also they're much more likely to act on it. So that's really key. To me, it's 100%, it just makes so much sense. The other part of what you brought up was with the vaccine, with the vaccine participation. There's actually a lot of studies showing there's these micro communities that actually had higher or lower vaccination rates than their regions. And so they're looking into why that's the case. And what they're finding is actually community leaders. Someone from the community just like them representing a particular view. And people just tend to say yes to those that they seem to be like them. These were not community leaders that were in a position of preaching necessarily. They were just somebody in the community. Again, it's somebody that's just like them. Yep. And I think that's really, it's really telling. It's really important.
Yeah, we've talked about this whole notion of, trusting yourself versus your doctor, right? It's interesting to think about it in the context of, even a vaccination question, and to your point, trusting a community leader, right, who you deem to have, more expertise or at least spent more time with, whatever the subject may be.
Yeah, and they may not actually, right? But
perception.
It's all perception. That's the whole thing. Remember, just giving people the information doesn't change their behavior. So you can be an expert, and you can come into the room and say, I'm the expert in this, and you need to take your medicine, or you need to do whatever, and you know what? It's just going to fall how it may. But if someone just like those people actually says, you ought to probably take your medicine, just that alone. There was a study actually, and I don't have the exact statistics, so I'm going to make up the statistics, but please don't focus on the number, focus on the story. Somebody once told me that if a doctor in a doctor-patient interaction just smiles and says hello and asks one question about the patient's life, the chances that patient will adhere to the regimen goes up. This is the statistic I'm going to make up, but I think it was something like 35%, some huge number. Just the doctor saying hello. Just saying, how are you? Tell me about your granddaughter or whatever it is. Just that. Right? So there's opportunity abound for us to have representation. That's likeness. This person's like me. They understand that I have a child, right? And that's all it is.
Well, it humanizes it too, right? And again, we're talking about this era of technological advancement and the shift away from that. Right, so finding those moments to do that, I think, is key. I know we're wrapping up and we want to give folks an opportunity to ask a few questions, but, always like to sort of end these conversations or discussions with some sort of call to action, right? Especially when you think about who's in the room and the innovative minds and leaders that we have that have influence over some of the things that we've been talking about. So, my question again is what can each of us be doing, right, to continue this notion of motivating the right behaviors, inspiring trust that really does change outcomes and improve well-being? What can we be doing?
Yeah. Let's go back to those sort of misperceptions maybe. I think if there's one thing that you want to take away from this that you can do right now is ask yourself how you're communicating, and especially with that audience, are they in an open mindset? Or can you get them to an open mindset before you give them the barrage of evidence? I think that's really a first critical thing. Just that. Just ask yourself the next time you're doing a presentation, whether it's to investors, whether it's you're trying to get a hospital system to adopt your system, whether you're a doctor trying to get a patient to adhere to something, just ask yourself, is this person in an open mindset? Or do I need to do something to get them there? Can I get them curious first, right? Because that just personalizes the entire thing. So that's, I would say, if you take nothing else and you just walk out right now, or if you just walked in, that's the thesis. The second one is that idea of the emotional cost. We don't tend to actually dive into that especially when we're trying to introduce new tech. So when a tech comes in, remember there's an emotional cost to somebody adopting that tech. It's not just about the shiny benefit. And so understanding what that is really important because then you can position it better and you can get adoption to go faster because then you're in control of that conversation. And then the third one actually is this idea of representation and likeness and how much that builds trust. Mm-hmm. So, people tend to act the part that you put them in. It's called priming effect. So you can actually prime people to want to think a certain way, and their actual, there's a material change in how people will act. And so make sure that you're priming them toward sort of the behaviors that you're hoping for or inspiring them toward that, rather than inadvertently priming them toward, another. Like, I walk into a healthcare system. If I'm just constantly primed that I'm sick, right, I feel crappy by the time I even reach the lobby, right? Versus if I'm primed that I'm healthy, active. I mean, somebody brought up Kaiser last time. The first time I saw the first Kaiser ad in 2000 about how Kaiser wants me to live long and thrive, I laughed. I'm like, really? Do they really? And then I went to a Kaiser institution and I was waiting for the elevator, and there was a sign that said, do you know you can burn 8 calories by taking the steps? And that was it. I was like, boom. That right there, the environment changed the way I felt about myself.
Some of it's so subtle, right?
I mean, it was something so simple, but then it started to build trust, and that's basically what it is that likeness and that representation, and just making sure that you're priming people that way.
Yep. So. Well, I think we've got a few minutes. We can maybe take 1 or 2 questions if there are any from the audience.
You're going to get one anyway.
Too late. What have you found works particularly well in getting patients to that point of openness and receptivity?
Yeah, I think so. That humanization is actually really important. And also, again, connecting something to their lives that maybe is that is a hidden need. That's the sort of the go-to trick that we have in identifying how to create curiosity. And let me just unpack that for a quick minute. So everyone's in their lives and they have these needs and they see their needs, right? But you as an innovator might actually have a different view on what's going on. And because you have that different view, you can actually break their reality. Like, oh, wait. So So by essentially changing the perspective on their lives and their own sort of sets of needs and saying, well, isn't have you ever thought about it from this perspective? That alone is a really big way of getting them curious enough. And that creates openness. What do you mean? Because remember, it's about them. It's not about your tech. It's not about the solution. It's about them. And that's the number one tool that we use. So in hero's journey language, which is like a template for how all stories are told, there's a moment in every movie where like you're watching the movie, you get to see the characters, you get to see what's going on, the barriers are there, and then there's something that happens and now you're hypnotized. You're no longer you are the main character, right? You cry when they cry. You feel the pain when they feel the pain. What happened? In that moment is when they changed the frame for you. They changed the perspective for you. Or they took you into the special world that you didn't know existed. It's the same thing, but more subtle. So.
I think I saw one more hand back here.
Awesome, thanks. Just to mention, my background's in behavioral economics, so interesting to hear you chat about it. When you were talking about breaking trust, like with the wearable, weight loss, exercise, I'm curious if you've seen research on or saw in your own lab how that might create ripple effects on how they want to engage with that topic at all. So like, would they want to continue in their weight loss journey? Or a doctor may be trying new technology. If they break trust with one, then they're skeptical about any new technology that comes through. So I'm just curious your thoughts on that. And then also from the perspective of the companies, if they ever sort of see themselves as the bearer of bringing new technology into someone's life that way beyond just their one point solution.
Yeah. It definitely, so with the work that we did with the Health Innovation Lab, that once that linearity was established and the user sort of sensed that it was not two-way, what specifically happened was they were much more reticent in sharing their information with the system. So it wasn't necessarily that they abandoned the system, but they just stopped logging. Because they're like, well, I'm giving all this information to the system, and it's not actually giving me the real, true feedback that I want. And so I have a distrust of it from that perspective. And some of them even as far as saying, this is a sham, they're just collecting data from me, right? So it was, it was a little bit of a range from that perspective. Whether it actually categorically ripples, we didn't necessarily see that. And in the work that we do a lot of work with like technical professionals and how they adopt technology. So, we work a lot more with like, how does a doctor adopt a technology, or how does a hospital system or even a scientist? We haven't seen as much categorization, but there is categorization that actually propels them toward technology. It's called a pro-innovation bias. You know this better than I do. Invoking a sense of pro-innovation bias actually gets them to be more pro-tech. So you remind them of how technologically advanced they want to be in their own sort of inner view of themselves. Subtle cue. They tend to shift toward a more technology relationship. If they've had a bad relationship or a bad experience with that specific technology, then it's an opportunity to create another category or create a new category, because some categories actually do have bad. Like in the science world, there's electronic lab notebooks. So you can all imagine the scientific lab notebook, right? It's the same thing as an electronic health record, but for scientists. Show me a scientist who uses one, and I'll show you one who's been forced to use one. They hate them. They hate them. And so it's time for let's ditch the category. Let's create a new one. And I think that's maybe a better opportunity if the category kind of has issues with it.
Well, I think we are right at time. So Hamid, I certainly appreciate and know the audience appreciates the time that you spent with us.
You.
Audience, I appreciate you guys being so engaged. I know that each of us is walking away from this conversation more conscious, more introspective about the work that we're doing.
Thank you.
So we appreciate your insights.
Thank you.
So thanks everybody for joining us.
Yeah, thank you. Thanks for having me.